Good evening, everybody. Welcome to the BTOG Mesothelioma Essential Update. Thank you very much for joining us. My name is Tom Newsom-Davis. I'm a medical oncologist from London and proud, as they say, to be the Vice Chair of the BTOG Steering Committee. We're very grateful for the support of our sponsors this evening, which include Hodge Jones and Allen, Lee Day, and Erwin Mitchell. Getting my clicker to work. Here we go. The most important people, of course, of the evening are Dawn and Gina. If you have any questions regarding BTOG or you'd like to become a BTOG member, please follow the websites listed here and you can have a look and sign up. Just to talk very briefly about the BTOG conference we had last month, it was an amazing success. And I must admit of going into it with some trepidation as to how many people would join up and how many people would be part of it. We had 1,500 people register and just under 1,200 on the day being part of the meetings on the Thursday and the Friday, which was absolutely fantastic. Huge numbers in each session, and we were extremely pleased about that and delighted to welcome the hardcore of you back to the mesothelioma meeting this evening. So please send your questions coming. I have with my phone here. Your questions will come through. So do please ask me. If you'd like to put in your name and where you're from, like in blind date, that would be fantastic. It's always good fun to hear that. And to remind people that we do have CPD registration for this meeting. If you send your feedback form, you will get a CPD registration form back. So skipping forward without me doing it. So I'm just going to go back. So this is the agenda of what we're going to do today. I'm going to introduce to you what can only be described as the Holy Trinity of BTOG. So we have Professor Sanjay Popat, who's a medical oncologist from the Royal Marsden Hospital, Mr. John Edwards, who is a thoracic surgeon from Sheffield Hospital, and Professor Corinne Favour-Finn, who is a clinical oncologist from the Christie in Manchester. And we're going to go through the three subjects here, and then we're going to do a bit of a Q&A at the end of it. So send the questions through, and I'd be delighted to grill the speakers on your behalf. Okay, so without any further ado, I will hand over to Sanjay, who's going to take us off on the drug treatments for mesothelioma.
Thank you, Tom, and thank you everybody for dialing in. It's been a really exciting time in mesothelioma. In the next 15 minutes, I'm going to give you an update of where we are now at and where we're going to in the treatment of mesothelioma. So we've changed a lot in terms of our attitudes and treatments over the last 20 years. We had mesothelioma being untreatable in the 2000s, a questionable role for mesothelioma. In the early 2000s, consideration of surgery from the mid-2000s onwards, colleagues confirming that postoperative radiotherapy has little, if any, value from 2016 onwards. And then we enter the immunotherapy era with a potential major role in mesothelioma from 2017, moving from a can't do to a can do attitude, which is fantastic for our patients. So if you take home nothing from this talk, it is this message. Immune checkpoint inhibitors, or CPI, are now standard for inoperable pleural mesothelioma. The only two questions we've really got to ask is who needs upfront chemo, and should chemo be given with checkpoint inhibitors? And here's the data that underpins these statements. So the biggest data set we have now, and the most important data set, is the Checkmate 743 trial, which was presented at the World Lung Presidential Symposium in August of last year and is now published in The Lancet. And we had an update, which I was privileged to present on behalf of my co-authors at the IMIG meeting last week. This is the first-line randomized phase 3 trial of patients with inoperable pleural mesothelioma with good performance status 0 to 1 who are randomized to receive either standard chemotherapy, cisplatin, or carboplatin with pemetrexed for up to 6 cycles, which is what we do all the time, or the experimental regime of nivolumab at 3 milligrams per kilogram every 2 weeks, or ipilimumab low dose 1 milligram every 6 weeks, with the regime carried on for 2 years. The primary endpoint was overall survival, and there's a number of secondary endpoints, as you can see there. Now, the trial met the overall survival primary endpoint with a really very impressive median overall survival of 18.1 months for nivolumab and ipilimumab. And if you look at the right-hand side of the panel, you can see that the performance of immunotherapy was pretty consistent regardless of histology. In epithelioid, 18.7 months, and in non-epithelioid, 18.1 months, which is remarkable. And if you look at the performance of chemotherapy, you can see in the epithelioid subtypes, it's inferior to what we see with immunotherapy, with a median of 16.5 months. And what you see with the non-epithelioid subtype is what we see in routine practice, a median survival with chemotherapy of around 8.8 months. And so in the non-epithelioid, we're having a hazard ratio of overall survival of a spectacular 0.46. So what does this mean? Well, this has to be put into context with the quality of life data, which we presented at the IMIG meeting of last week. And if we look at the average symptom burden index, what are patients feeling from baseline, and compare it through chemotherapy or immunotherapy, you can see with these series of graphs, with the patients with epithelioid subtype, we see a persistent ongoing improvement in symptom burden index with immunotherapy, with a deterioration in patients with chemotherapy. And while we look at what's happening with the non-epithelioids, we see significant and early significant improvement in the symptom burden index when it seems to be maintained for patients on chemotherapy. Now, here's really what's really interesting. If you look at the overall health status, which is measured using a score called EQ5D3L, you can see that in the epithelioid subtype, the overall health status significantly improves, where actually it deteriorates a little bit for chemotherapy. Whereas in the non-epithelioids, we're having the overall health status improving to what the UK population normal should be at. And it's markedly deteriorating for what we see with chemotherapy. So overall, the improvements in overall survival are underpinned with improvements in quality of life for our patients as well. Now, this all needs to be borne in mind, because one of the problems we have is that if you look at progression-free survival, there is crossover of the curves before 7 months, which means that in about 10 to 20% of patients within the first 7 months, chemotherapy is possibly the superior option in terms of time to progression, whereas overall later, from about 7 months onwards, in terms of progression, immunotherapy is superior. And the other thing we need to bear in mind is the adverse events. So we have similar numbers of grade 3 to 4 treatment-related adverse events for Nivo and Ipi versus chemo. But you know, the quality of adverse events for Nivo and Ipi is very different to those for chemotherapy, which are usually reversible with time alone. And you can see there's almost doubling of the discontinuation of treatment rate due to treatment-related adverse events. So we need to be mindful of the side effects of immunotherapy for the patients that we're thinking about. So the conclusions for immunotherapy is that Nivo-Ipi is superior to chemotherapy with consistent performance across histology, and in the non-epithelioid subtype, there's a marked overall survival benefit with little chemotherapy activity, big quality of life benefit with normalization of the health utility to the UK population. And in the epithelioid subtype, we have a more modest but important overall survival benefit with more nuanced discussion for patients regarding risks and benefits. If we might be using chemo and Bev as the comparator. If we're using chemo as a comparator, well, it's no question. We want to use Nivo and Ipi. But nevertheless, we still see quality of life improvement compared to chemotherapy. So Nivo-Ipi is the new standard of care, especially for non-epithelioid subtype, and it is available today in an early access to medicine scheme, at least in England. So what does this mean? This means pathologists must report the subtype of malignant pleural mesothelioma. Now, this data is suitable only to PS0 to 1 patients, and we note the inferior PFS within the first 7 months. So for some patients, chemotherapy followed by immunotherapy may be the better strategy. And of course, this is not telling us anything about our surgical patients, so this is not appropriate for a surgical paradigm. So what do we know about relapsed mesothelioma? Well, my colleague Dean Fennell presented the CONFIRM trial very recently, And this trial, we all participated in this in the UK, patients that had relapsed after chemotherapy and after one or perhaps two lines of treatment. The majority of patients were third-line patients, were randomized to receive nivolumab or placebo with survival as the primary endpoint. Not nivo-ipi, but just nivolumab. Now, what did this trial show? The primary endpoint was overall survival, and we did see a significant overall survival advantage compared to placebo. So not treating versus giving immunotherapy, we see a big survival benefit with a hazard ratio of 0.72. And this is mainly driven by the epithelioid subtype, which is deriving the benefit, not the lower right-hand corner, the non-epithelioid subtype, which seems to derive no benefit. So you're saying to me, hang on, this is a bit weird, because didn't Popat, you present to us the PROMISE data, which showed no benefit from immunotherapy? Well, if we look at both of these trials, PROMISE, the crossover arm of PROMISE, and CONFIRM, we're seeing the same thing. We're seeing a consistency of checkpoint inhibitor efficacy. If we look at 6 months PFS, median PFS, 1 year overall survival, and median overall survival, the statistics are pretty much similar. So immunotherapy provides a consistent benefit in the relapse setting. It's just that the comparators in these two trials, PROMISE and CONFIRM, were different. Indeed, if you look at the outcomes of the non-epithelioid group, which is, this slide has become poorly formatted when it's been grouped together. You can actually see that the non-epithelioid outcomes are equally poor for both the PROMISE group and the CONFIRM group. So they're both consistent. If you have a non-epithelioid patient, don't bother with immunotherapy second line, they won't get there. Give it to them first line. That's the key take-home message. So the conclusions for CONFIRM: big, meaningful overall survival benefit, 1 year of nivolumab versus supportive care, little overall survival benefit in non-epithelioids. We didn't talk about PD-L1, we can do that, but the bottom line is it's not ready for prime time use. Where are we going with trials? In the first line setting, this is where all the action is. We have the BEAT MESO trial, recruiting, randomizing patients to the best comparator arm at the moment, Carbo Pembev, which I think is a very reasonable suggestion for patients with epithelioid disease, randomizing them to that with the addition of atezolizumab. And we also, in other parts of the UK, of the world, have the DREAMER trial looking at the addition of durvalumab. This trial will be very difficult, I think, to recruit to in places where they have immunotherapy already available. And the Canadian global trial, which is recruited, and we're waiting the number of events, looking at the addition of pembrolizumab to chemotherapy. So what about other treatments for relapsed mesothelioma? We just need to bear in mind there are other treatments. So this is in the pre-immunotherapy world. If you started first-line chemotherapy and you've still got some patients going through, you could consider switch maintenance gemcitabine. The ENVALT-19 study demonstrated a significant PFS benefit, but because of crossover, no overall survival advantage, and we know the toxicities of gemcitabine very well. And we shouldn't forget the Italian RAMES trial, in which patients in the second line setting were randomized to receive gemcitabine or gemcitabine plus ramucirumab with a significant survival advantage, albeit this being a phase 2 trial, meaning that there's increased likelihood of type 1 error with the statistical design. Finally, what about experimental treatments? Well, the big experimental series of treatments going through in the UK is the MIST trial, led by our colleague Professor Fennell at Leicester. We have 5 arms. The first 2 arms are biomarker stratified BAP1 loss or CDKN2A or P16 loss, and 3 arms, 3, 4, and 5, having combinations of immune checkpoint inhibitors. Now, we've already had data from the first arm, which Dean has presented previously and is now published, showing in patients with BAP1 or BRCA loss, giving rucaparib, a PARP inhibitor, has a response rate of 12%. To me, a little bit disappointing. The fact that we had any responses at all, I think, is good news. And Dean is proposing another trial looking at maintenance niraparib following chemotherapy versus immunotherapy. Now, I think this may need to have some recheck given the data that we have. And the final other thing to say, that there are major changes afoot with pathology. At the IMIG meeting, we had an update from the WHO reclassification of mesothelioma. There are 4 things you need to know about. First of all, there's a condition called well-differentiated papillary mesothelioma. That's a low-grade tumor which does very well. That's now called a different term. That's called a well-differentiated papillary mesothelial tumor. Second, the word malignant has been removed from all definitions of mesothelioma because they are malignant by definition. Third, pathologists are asked to specify the architectural patterns and cytological features. Now, that's important because we as clinicians need to know what grade it is. Is this a high-grade tumor which needs treatment straight away, or a lower-grade tumor which may not need treatment straight away and can help with prognosis? And the fourth and most important point is there is a new diagnosis we need to know about. This is called mesothelioma in situ. This is a pre-malignant stage of invasive malignant mesothelioma. This is defined as a single layer of atypical cells when the surgeon can't see any abnormality at microscopy, at thoracoscopy, and the pathologist can't see anything other than the single layer of cells, and the radiologist says there's no pleural rind. This is a pre-malignant status, and it's important. There is BAP1 and CDKN2A status known on this tumor, and we don't really know how it should be managed. Should they undergo surgery? We don't know the natural history. We don't even know really how to classify it according to stage because it doesn't yet exist. So big news, and we need to start using these terms in our routine day-to-day practice. And with that, I'd like to thank you very much for this whirlwind tour of systemic therapies. I'd like now to hand over to my colleague, Mr. John Edwards. John, you'll all know very well, who is lead thoracic surgeon and a leading light in the world of thoracic surgery for malignant pleural mesothelioma. John, over to you for your section.
So thank you. So I'm going to be giving an update on surgical aspects, but I think predominantly the update may well come in discussion, because I think rather than me bleat on about what we should be doing and could be doing now, I think it would be more interesting to bring people in on that discussion. So I think it's always good to go back to what is the goal of surgery in cancer. And again, radical surgery is about trying to achieve a negative microscopic margin, and the goal there is local control. Now, that obviously hits the buffers with mesothelioma in the basis that we are unable to achieve lasting local control. And therefore, the buzzword really is complete macroscopic resection. Palliative surgery, again, may well be justified. We're not looking at trying to get negative margins, but we're trying to improve symptom palliation. And so when we're looking at the justification between the balance of risks and benefits, and the palliative surgery is about improving the quality of life, which may or may not improve survival. Radical surgery, in inverted commas, about improving survival, which may or may not improve quality of life. And the definitions of surgery are now well established. I know that there is continued discussion with people trying to think differently about some of these terms, but this is the best that we have, and it's clearly important to talk in consistent language and terminology. So when it comes to partial pleurectomy, the intention is not to gain a complete macroscopic resection, but is to try and improve the chest wall dynamics by removing the pleural tumor from the costal surface, and also potentially from the lung surface, compared to what all one would achieve with a pleurodesis, which is lung expansion. And the results of the MESO-VATS trial are well renowned. And the fact that there were 196 patients randomized between TALC pleurodesis and VATS pleurectomy, and that there was no survival benefit seen between those two groups. I think it's quite useful to look again at the quality of life data that's achieved. Bearing in mind, if we just go back one slide, we're looking at the potentially those patients at 12 months and beyond. So we're looking at 45 or 50 patients at 12 months who are assessed for their quality of life. And this compares very similarly to the data in the Checkmate 743 study, where there were similar numbers of patients in some of those groups, and comments being made about the quality of life in them. And we can see here that although quality of life was only measured out to 12 months, there was a benefit in those that made it that far. And I think this is perhaps a recurring theme that we could pick up in discussion with Sanjay, is in terms of how does one best work out who is going to be a longer term survivor, because they are going to be the ones that may receive benefits from in a number of different types of treatment. And the same with lung function. There were modest changes that were not statistically significant in the MESO-VATS study. In terms of the Mesotrap trial, this was a kind of follow-on study from the same investigators, looking at patients with a trapped lung. And the intention was to determine the feasibility initially to randomize 36 patients in 18 months. And these data were again presented by Robert at IMIG last week. And you can see here on the left the degree of selection that was required to identify patients with a trapped lung, in that over 1,000 patients were screened for Mesotrap at 18 sites, and yet there were only 108 patients that were found to have a trapped lung. So that's about 10%. And of those, by the time there were exclusions, which you can see on the right-hand side, only 10 patients ended up being able to be randomized. And so this study shows that we're going to struggle with feasibility for a study looking at VATS partial thoracotomy with the decortication element for patients with a trapped lung. At the other end of the scale, again, the results of the Mars trial originally of extrapleural pneumonectomy versus not are well known and have been well discussed. Again, modest changes in quality of life, but look, in terms of survival, but again, look here at the number at risk. So in the 12-month group, the numbers at risk were very small, and so hence it's very difficult to come up with any firm comments about either survival or indeed in terms of quality of life. The numbers are just not there, but again, it's well recognized that the feasibility of us performing a randomized trial to investigate extrapleural pneumonectomy further, the feasibility is just not there. Having said that, there are groups that are continuing with their investigation of extrapleural pneumonectomy, and I know that Karina is going to say something about the Toronto group and their SMART protocol of induction IMRT radiotherapy immediately prior to surgery, 1 week prior to extrapleural pneumonectomy. And they've presented in Lancet Oncology data on 102, I think it was, very carefully selected patients. But I think the important thing to be looking at that is look at the survival of that selected group undergoing that select protocol. They've moved then into a smarter protocol, which, if you look on the right, includes either extrapleural pneumonectomy or EPD. And it's interesting to note that in this effectively phase 2 study, these patients have undergone EPD rather than extrapleural pneumonectomy. So what they are demonstrating is that there is so far some feasibility of performing IMRT prior to surgery. But when pressed as to whether they could perform a randomized study, when we discussed this at IMIG last week, it seemed unlikely that the Toronto group are going to be in a position to perform a randomized study. What about extended correctomy decortication and our beloved MARS-2 trial? And you can see here, of course, that this was a tremendous effort with a wide range of people in different centers who took part in MARS-2. And the schema, I think, is well known in terms of having 2 cycles of platinum pemetrexed chemotherapy up front, followed by a CT scan, and then randomization to either surgery, followed by 4 cycles, or just going on to the up to 4 cycles of chemotherapy. And accrual, again, is well recognized that in January this year, the 335th randomization was performed, which is a fantastic effort for a surgical trial. And I'm sure that when these results the results of the primary outcomes are announced in 2 or 3 years' time, we're going to learn an awful lot from MARS-2. However, we can learn some things from the process already in terms of the selection, and also get some ideas of where we may be heading. I presented last week some of the results of our screening to the patients that were referred to us from the different centers, and looking again at some of the degree of selectivity according to the patients that ended up being randomized. And what I wanted to do is to look at some of the reasons why people were screened and maybe not even made it as far as a screening log before these were universal in the study. And you can see here the degree of selectivity. And when one looks at it by different center, with our own center at the top, including every patient with mesothelioma within our specialist mesothelioma MDT. So this is without any degree of selection whatsoever. You can see that there are about 13% of our patients, 38 out of 316, that were that were enrolled in the study, the percentage from the other centres was greater, but of course there was selectivity in those that were referred to us. But what was interesting was to look at those coloured columns in terms of the outcomes. Obviously, it's not appropriate to split the survival in those 95 randomised patients, but I think it is quite useful to get some idea of that selectivity and what that means in terms of survival. So these were the curves of those groups, and you can see that those that were enrolled and randomised had a pretty decent survival here in days. It will be in months on the next slide, compared to those that withdrew, declined, or were ineligible for the study. And if you look at it in terms of numbers, the suggestion here is that 27-month median survival was achieved amongst those patients that were randomised. And that, I think, compares very favourably with the degree of selectivity in the other studies. One of the issues with the original Mars study was that one of the criticisms was about the survival rate. And I think we're going to see here that we've got very comparable survival rates with the general surgical literature. So where do we go next? Well, David Waller, one of course, the leading surgeons behind the Mars 2 program, presented a number of issues in terms of where we might go with Mars 3, looking at the different aspects such as the degree of preoperative selection with more detailed surgical assessment, how we look to integrate with various induction regimes, and clearly it seems that immunotherapy will have to be within there, but there is the potential for including it in different ways. And then learning what we have in terms of doing our best to spare organs, and that may include the diaphragm as well as the pericardium in terms of our surgical techniques. So with my final slide, I guess the issue is that we can make some generalizations about the current status about palliative surgery, which shows a modest quality of life benefit that hasn't really been acted upon. And that may be a discussion point, but with no proven survival benefit. And again, that we're not going to be able to look further at trapped lung, which is a surprise and also, I guess, unfortunate. In terms of that radical surgery, of course, we're waiting for the results of Mars 2, which are going to be more informative than any study to date, but which was applicable to less than 12% of patients in terms of enrollment. And the survival rates, as I've said, seem to be comparable. And it seems that a randomized trial of extrapleural pneumonectomy versus not is not going to be feasible. But do we need to have a closer look in the trial setting in the UK, knowing that we can deliver very effectively in terms of our trials? Do we need to look more closely at the radiotherapy and integrating that? Perhaps that's something that we can discuss. But equally, what should we do now that Mars 2 has reached accrual? And I imagine that will come up in the discussion. How should we be proceeding? Should we continue to operate, or what should we be doing at this current moment in time? And how are we going to use that in terms of, as systemic therapy includes checkpoint inhibitors, how is that going to be incorporated into further surgeries of study of extended thoracic decortication, and potentially with radiotherapy with SMARTA? So with that, I'll move on to our third esteemed speaker, and Corinne, it's over to you.
Many thanks, John, and I'd like to thank the BTOG organizers and Sanjay for asking me to talk about a radiotherapy update in the treatment of mesothelioma. So clearly the star of the show today is Sanjay with a result of checkmate 743, but nonetheless, I will tell you about where radiotherapy fits in the management of mesothelioma. So this is what I'm going to cover: prophylactic radiotherapy, perioperative radiotherapy, and then finally palliative radiotherapy. And in terms of recommendation for standard practice, I will refer to the ERS-ESTS ESTRO guidelines published in 2020. But there are a number of other guidelines that are available, published between 2018 and 2020. And I had the privilege in taking part in all of them except for the ASCO guidelines. The latest guidelines led by Sanjay, which are the ESMO guidelines, I was hoping to give you a little peek of it, but unfortunately the paper is currently under review, so I will not be able to tell you about them, but I think it's fair to say that with regards to radiotherapy, there is no major change compared to the ERS-ESTS-ESTRO guidelines. So I'm going to start with prophylactic irradiation of tracts, and this is what we're trying to avoid, these nodules on a chest wall that can sometimes be painful after procedures such as thoracotomy, thoracoscopies, insertions of drains. And the practice in the UK, certainly when we did a survey of practice in 2009, was to routinely deliver prophylactic irradiation of tracts, and that was the case in 80% of the centres in the UK. That was, however, based on small studies that were underpowered with conflicting results. But now we can put our mind at rest. We have two definitive UK trials, one so-called SMART trial and then the PIT trial that were published in 2016 and 2019. And very importantly, these trials were done in the modern era of chemotherapy, which was not the case with previous trials. You can see that with a SMART study comparing immediate to deferred radiotherapy to tracts, there was no significant difference between immediate or deferred radiotherapy, whether you look at the primary intention to treat analysis or whether you look at patients developing chest wall nodules anywhere on the ipsilateral hemithorax. And then the PIT study, which had, as you can see, a slightly different endpoint to the SMART study, then again did not show any difference between irradiation of tracts and no irradiation of tracts. And you can see the differences between the two studies. So in terms of inclusion, there was no inclusion of open thoracotomy and dwelling pleural catheter in the PIT study, and it was the case in SMART. There were differences with regards to the radiotherapy field size and, as outlined, differences in primary endpoint. So what does ERS-ESTS-ESTRO recommend? Should radiotherapy be used to prevent procedure tract metastasis in patients with mesothelioma? Well, the recommendation is that we should not recommend prophylactic drain site radiotherapy in the routine clinical care. So I think we can put that one to rest. Now, moving on to perioperative radiotherapy. So you've heard John talking about the various procedures that are available. And I think it's fair to say that most of the studies that are in the literature were done in the context of extrapleural pneumonectomy, which is no longer a standard radical procedure in the UK, in the vast majority of the centres. So we have one randomized controlled trial of looking at the role of hemithoracic radiotherapy post-operatively. So this is quite a complex study done in two parts. So the first part was about the feasibility of the surgery and the macroscopic resection. So patients PS01, age below 70, had 3 cycles of chemo, then surgery with EPP. If then they had an R0 or R1 resection, they could be randomized between radiotherapy and no radiotherapy. So you can see there's quite a big attrition rate from the beginning of a treatment with chemotherapy surgery all the way to randomization to radiotherapy or no radiotherapy. The primary endpoint with regards to part 2 of the trial was local regional relapse-free survival. And as you can see from the figures on the right-hand side and the graph, no significant difference between the two groups. Also no difference in relapse-free survival and no difference in overall survival. But bear in mind that this study was closed early due to poor accrual and was therefore underpowered. Now, clearly, we've heard that protomy decortication is now becoming more standard in the surgical setting. So there are 2 prospective studies that demonstrated that hemithoracic pleural IMRT after EPD is feasible, has an acceptable toxicity profile, and has quite a good median survival of up to 26 months. And this is now leading to the ongoing Energy LU006 randomized phase 3 trial that is randomizing patients after prolectomy decortication and chemotherapy that can be given either neoadjuvantly or after surgery. And the patients are randomized 1-to-1 between IMRT, post-op versus no adjuvant IMRT. The primary objective is improvement in median overall survival from 12 to 20 months. And then this was the breaking news at ESTRO 2019, radiotherapy double survival for patients with mesothelioma. So that sounds quite intriguing. So this study is done in a slightly different setting. So in patients who have lung-sparing surgery, but non-radical lung-sparing surgery, so proven gross residual disease, PS 0 to 2 patients, and they're randomized between radical hemithoracic radiotherapy or palliative radiotherapy. You can see the doses on this graph. So 108 patients were randomized. In terms of 2-year survival, 58% in the high-dose radiotherapy group compared to 28% in the palliative group. Median survival, 25 versus 12 months, and that is comparable to SMART. So you can see the big differences in survival. In terms of toxicity, high-dose radiotherapy was associated with 20% acute grade 3 or more toxicity, and 31 patients had grade 3-4 late toxicity. So fairly toxic treatment, and this is intriguing but needs a larger confirmatory study. Now, you heard John talking about the very intriguing, and I have to say, fairly worrying SMART regimen. So not to be confused with the SMART study that took place in the UK of irradiation of tracts. So this is the Toronto study. So this was a phase 2 feasibility study in PS02 patients who were resectable. And what's really scary is that hemithoracic radiotherapy to a dose of the whole hemithorax to a dose of 25 in 5 fractions with a 5 gray boost is delivered prior to EPP. And then EPP has to be given very quickly because obviously you want to avoid major lung toxicity. And in this study, they gave the EPP was done at a median of 5 days after IMRT. They enrolled 102 patients, and their aim was to demonstrate feasibility, which was defined as a number of patients with grade 3-5 within 30 days of surgery. They had a pre-specified threshold of 35%. Now, as you can see from the results here in the middle, unfortunately, almost half of the patients had 30-day pre-operative grade 3-4 events. So therefore, this was not only a morbid treatment, but the feasibility threshold was exceeded. However, a median overall survival of 24.4 months, which is one of the highest reported in this setting, is very encouraging, and clearly multi-center studies are needed, but as highlighted by John, the likelihood of a randomized trial is probably unlikely, and the SMART study, which I won't go back to, is ongoing. So what does ERS-ESTS ESTRO recommend? Should adjuvant post-op radiotherapy be used in patients with mesothelioma? The answer is that radiotherapy, whether it's done after PD or EPP, should only be considered within the context of clinical trials and or included in national or international surgical registries, which is a very sensible recommendation. Now, the final part of the talk is radiotherapy for symptom palliation. So many of our patients have local infiltration of a chest wall, vertebral bodies, and other structures, causing symptoms, particularly pain. So can radiotherapy help with the aim to palliate the symptoms? So we had up to 2015, a number of very small single center retrospective studies that had been done with a wide variation of radiotherapy dose and techniques, and there was limited evidence to support the use of palliative radiotherapy to treat pain. Now, the systems trial was published in 2015, and in this study, patients received a dose of 20 grain 5 fractions with parallel pairs to palliate the pain. They had a symptom assessment at various time points, and the primary endpoint was palliation of pain at week 5. And as you can see from the waterfall plots on the right-hand side, quite a third of all patients recruited an improvement of pain at week 5. And if you look at those patients still alive, it was almost 1 in 2 patients. So that led to the development of a Systems 2 trial, which is ongoing. This time a randomized study that is comparing the dose of radiotherapy used in systems, 20 in 5, to a higher dose, 36 in 6 or 30 in 5. This is a multi-center phase 2 randomized dose escalation study, recruiting in a number of UK centers, using more modern radiotherapy techniques this time, IMRT or 3D conformal radiotherapy. And I was very pleased to hear today from Noel O'Rourke that 85 patients out of 112 have now been recruited, which is a fantastic achievement. So again, back to our guidelines, what do they recommend? It is suggested that palliative radiotherapy for pain relief should be considered in case of painful sites of disease caused by local infiltration of normal structures. Now, we've heard from Sanjay about the fantastic results of Checkmate 743, and an important question is, where does radiotherapy fit in the context of immunotherapy? So we know that radiotherapy has been shown to increase tumor cell immunogenicity, as well as inducing an immune response to neoantigens. And although the role of sequencing of radiotherapy with immunotherapy has been well studied and continues to be studied in lung cancer, particularly non-small cell lung cancer, it's not quite the case in the setting of mesothelioma. So there are a number of studies ongoing looking at the feasibility of combining stereotactic radiotherapy with immunotherapy, and one of them was presented at World Lung last year by Dr. Rimner. It's a safety study of avelumab, which is an anti-PD-L1 plus SBRT, and they demonstrated that this combination is safe, with 15% of patients experiencing grade 3 or more toxicity, with response and survival rates consistent with previously published results. And then in the UK, we have a Mesoprime study led by Dr. MacDonald and Dr. Harrow, combining pembrolizumab with SBRT. And this study is at the very early stages of recruitment. I think only 3 patients to date have been included in this phase 1 study with an expansion cohort. So this is my final slide, the gray areas and where we need clinical trials. So since more and more of our patients live longer with better treatments, particularly with immunotherapy, we now have this concept of oligorecurrent mesothelioma. And there's some data, although very limited to date, about the role of hypofractionated or SABR in this context, and we need more. And then what about proton therapy? So I've told you before that standard 3D conformal or IMRT treatment is fairly morbid and can cause mortality as well. We know with proton therapy there are clear dosimetric advantages, but we have to date no robust comparative data on protons versus photons. And there was a consensus statement on proton therapy in mesothelioma that was published last year from a US group, and they suggested that IMPT, so immunomodulated proton therapy, should be considered when available and delivered by experienced multidisciplinary teams. But clearly, we need more studies in this field. And with that, I'd like to thank you very much, and I will hand over to Tom.
Corinne, thank you very much. Also to Sanjay and to John, the 3 graces, I think, of BTOG and mesothelioma. So the great thing about having speakers like you guys is that you don't have to worry about running to time. because they all run to time, even despite John's impressive array of slides. And what I thought was an extraordinary experience, which was hearing thunder in Sanjay's presentation, then me hearing it about 5 seconds later. I'm I think about 5 miles west of you, Sanjay. So that was an interesting experience. We've got some good questions coming through. They're all anonymous. Come on, be brave, put your name down. I'd love to hear it. So first of all, we're going to think about pathology, Sanjay. So the first one goes to you. The mesothelioma in situ. If you can't see it on surgery CT, how do we reach it? And how do you diagnose it, and how do you find it?
So these are patients that present with a pleural effusion, and John will be putting his scope in, doing a VATS. He'll be having a hunt around. He'll be taking a few biopsies for good measure. And these were patients with usually a asbestos history, where you might be just concerned there might be something going on there. So that's what prompts the investigations in the first place. And it's really important because not every single patient with mesothelioma in situ goes on to develop invasive, diffuse, malignant mesothelioma as you and I know it, but a sizable proportion do. And we need to get a better understanding of this phenomenon, because really the key question is, does John need to go in and operate on those patients at the pre-malignant stage or not? And these are some of the questions. But we really need, I think, to start getting our pathology a bit tighter than we have at the moment.
John, you very politely got your hand up.
Indeed. I think the important thing is that we indeed don't know enough about mesothelioma in situ, and my suspicion is that it will also be a diffuse process. We just don't know enough, but certainly the first time that we see mesothelioma, it is a diffuse process, and it doesn't really matter where you take the biopsy. And I suspect the same will also be true for this. But I think the key message for thoracoscopists of either surgical or respiratory persuasion is to ensure that multiple biopsies are taken from multiple sites. And I think that is also a key message when it comes down to the stratification of patients for therapy. Sanjay mentioned that, but I think it is worthy of emphasis that it is crucial to ensure that we know whether this is a pure epithelioid or whether this is actually a biphasic tumour, seeming as it seems that alone is a sufficient stratifier to change potentially completely our first-line treatment.
Thank you, Tom. In fact, we talked a little bit there about the importance of pinning our pathology colleagues down as to the subtype of mesothelioma. What should our colleagues be saying to their surgical colleagues in the MDT? So they've had the VATS, and the surgical colleagues have done the VATS and about to move on to the next patient. What should we be quizzing them about, or what was seen, if we're going to be making sure that we have properly assessed our mesothelioma patients? And people presenting with an effusion, sorry, which has been investigated.
So I think the important contribution of the thoracoscopist, and dare I say it, predominantly this is probably swinging more to local anaesthetic thoracoscopy than surgical in many centres, our own in particular, as well as many others. But I think what the thoracoscopist can contribute is the T stage of the tumour, and so that that is as much a visual assessment as it is a radiological one. Quite often you will see a T1 tumour at thoracoscopy with nothing to see on the CT scan. So I think that is very important, and particularly when talking within the MDT setting, to be able to say that there were definite nodules seen and this looks like barn door mesothelioma, that then assists the MDT when the pathologist perhaps might not see invasion on the biopsies taken. So I think the dialogue and the role, therefore, of a mesothelioma MDT is really crucial in determining the correct starting point for decision making.
Thank you very much. And just to say, that question was from Izia de la Vina, who's very kindly sent through their name. Sorry for shaming you. We have a question from Clive Pedell, well known to everyone. Very good shoes, I believe, in BTOG meeting last month. Occasionally we come across cases where the mesothelioma is very localized and ball-shaped. Do these cases behave differently, and how should we manage them? And that's for anyone who has an opinion.
Yeah, well, I'm happy to start. I mean, you know, these cases are not few and far between, but they do come up, and they're localized mesothelioma. They have a different natural history, and they tend to be less diffuse. And personally, if you are going to operate on any form of disease, that's the type of disease that you should be operating on, frankly. And I don't think we necessarily need a trial to definitely tell us that. But I'm interested in John's views. But my view on that is we should be aggressively managing those, assuming, of course, they're not a poor prognostic tumor, which is sarcomatoid in the first place.
So I think Sanjay's last phrase was the important thing, is assuming that it's not diffuse. And experience that I've had tells me that probably half the time that you have a case which you think is a localized mesothelioma, you perform a thoracoscopy and you find that it is not. And that is a problem. We've also seen recently a case which I may term slightly curiously a multifocal localized mesothelioma, where there was a case with two very definite chest wall masses that were very definitely mesothelioma, and yet when we performed a pleurectomy, the rest of the pleura was entirely normal. So there are some very strange subtypes out there, and certainly it's reasonably well established, if one does a non-academic systematic review of the literature, that localized mesothelioma has a better prognosis. And it is really on that basis that we go for primary surgery, perhaps with some radiation as well if we're concerned about margins, because I think you can get local control for those. But perhaps this is an opportunity for, how should we put it, a BTOG real-world experience study, because we all have a number of cases. But if we put those cases together with a dedicated data set, I think we'll learn an awful lot more. So hadn't thought of this before, guys, but I think this is a BTOG real-world experience study in the making.
Great idea.
Keep Clive busy.
Heard it here first.
Well,
John, thank you very much.
He asked the question, so he has to do it.
Sanjay, just going to think a little bit about Checkmate 743. So amazing data, and this is great stuff, and clearly a change in what we do. And I think the argument is conclusively made for the non-epithelioids. These guys really benefit from combination immunotherapy, and chemo really doesn't work terribly well. There's a few questions here about, well, this is great for my epithelioid patients, but I don't see that many PS01 epithelioid mesotheliomas in my practice. What do I do? How do I decide whether to give them Niv-Ipi? I'm not terribly experienced with that. Perhaps it's not a combination we've used very much in lung cancer. I'm worried about side effects. I've seen your quality of life data, but you know, how do you advise someone to say now's the time for a combination immuno, or get on with your chemo and keep your immunotherapy up your sleeve for second line? What's your own practice?
Well, in terms of histology, it's a slam dunk for the biphasics and the sarcomatoid. There's no question about it, as long as they're reasonably well. And you have to remember, to go into this trial, the patient had to be sufficient to be randomized to either carboplatin and pemetrexed or cisplatin and pemetrexed as per investigator decision. So the basic issue is your patient suitable for either of those two comparators, aiming for 6 cycles of that, and that should give you a good feel as to the type of patient that you're after. Now, the other issue is about systems. So you have to have enough systems in place to ensure that you can deal with the toxicity of immune checkpoint inhibitors, because actually they're reasonable. Now, it is low dose IPI, but it does almost double the rate of immune-related adverse events that we see. It certainly doubles the rate of treatment discontinuations that we see. So you have to have systems in place to make sure that the patients that then develop adverse events are appropriately managed. So perhaps for some centers, it might be best treated in the cancer center rather than the cancer unit, but that should be done on a geography by geography basis, depending on what sort of infrastructure and backup that you have. The most important thing is that we don't really know who those patients are that are the 10 to 20% that progress early in the progression-free survival curve. We don't really have a good feel for that. Are they the ones that are the most symptomatic? Well, if we're talking about epithelioids, that may well be the case, because certainly our experience of patients that had really become systemically unwell with significant weight loss, night sweats, drenching night sweats. LDH was very high in the PROMISE study, and we see signals of this in the CONFIRM studies that checkpoint inhibitors really aren't good for that potential population. So I think we've got a lot of unknowns still out there from Checkmate 743. There is the other additional biomarker analysis coming through within the next 6 months, which I hope will really give us a better feel for how we can patient select. But I think a combination of understanding what your local systems are for patient safety and whether they're well enough to be being randomized to the comparator should give you a good feel for which patients you put in.
Thanks, Sanjay. And Corinne, do you think that Sanjay's just ruined it all for radiotherapists now? So we've got the combination immunotherapy. We need to be a little bit cautious with immunotherapy and radiotherapy together. The evidence behind radiotherapy in mesothelioma, as you beautifully laid out, is perhaps a little bit more limited than other treatments at the moment. Will this push it more into the background, or actually is this a great opportunity? Is this the opportunity for us to be achieving better control for patients now that we have better systemic options as well?
Yeah, for sure. So I think it's the same issue as what we have in the stage 3 non-small cell lung cancer setting is, now we're entering the era of immunotherapy. Where does that fit in the sort of multidisciplinary management paradigm? And we have exactly the same questions in mesothelioma. Now we know that immunotherapy in the first line setting improves survival, particularly in non-epithelioid. Then where does that fit in with potentially surgery and or radiotherapy, in some patients groups? But what's intriguing me, am I allowed to ask a quick question to Sanjay? Is
definitely.
The sort of lack of biomarker data in the mesothelioma setting compared to what's going on in non-small cell, because presumably the Checkmate 374 study doesn't have yet data on PD-L1.
No, we do.
Status.
We do. So we do have data on PD-L1, but it's an exploratory biomarker, and there was the hint that PD-L1 positive tumors did better. But the problem with that is you haven't controlled for your covariates, and we know that the non-epithelioids tend to be PD-L1 positive. So by the time you start getting down into the subgroups of epithelioid versus non-epithelioid versus PD-L1 positive versus PD-L1 negative, you really don't have much power in these balanced subgroups. So there's a bit more work that needs to be done around PD-L1. The other question we get asked around a lot is TMB, but we know that in mesothelioma, the TMB is always low. So it's not really a very good discriminator. So there are many other biomarkers that are being evaluated.
Thank you, Sanjay. We've got 3 minutes left. We've got a couple of questions coming through. One, I think, for John here. We've got a patient, for example, who wants to be referred up for MARS-2. Obviously, they're going to get the message back now saying, terribly sorry, MARS-2 has shut. Is there a role for extended decorrelation whilst we wait for the results of that? Should we be saying to patients, yes, that's something you can consider, or should we just be closing that until we have some trial data to support it either way?
I think it's very difficult, and I think that's down to some extent to patient, doctor, and surgeon choice. There are patients for whom it makes perhaps more sense, and those for perhaps it makes less sense. And I think if you were going to try to predict the potential benefits of surgery, it is probably easier to justify in patients with better prognostic factors such as tumor bulk, physical status, and so forth. So I think if you had an early stage epithelioid cell type in a very fit younger patient, it would seem reasonable to consider an offer in that case. But clearly that would be with appropriate counselling to state that the benefits are as yet unproven. The converse, I think, is equally true. But I think most surgeons will feel that there is a degree of acceptability, but clearly as the standard therapy changes and is likely to change whilst we're waiting for the results of MARS-2, we need to consider the alternatives of that, and whether that may be, for example, a MARS-3 protocol, which might appear quite quickly also.
Thank you very much. We are pretty much out of time. One very quick question to you, Corinne. I've got a message asking what the endpoints were for systems 2. Was that was that pain control, symptom control endpoints for that?
Yeah.
Okay, I think we're gonna wrap it up there. So thank you very much, everyone, and my fantastic speakers, Sanjay Popat, John Edwards, and Corinne Favour-Finn. Hope you found that as interesting as I did. We have some exciting things coming up. We've got ASCO in an hour in a month's time. That was actually our biggest selling, so to speak, webinar last year. So that's going to be on the 10th of June. ASCO itself being the week earlier, and it's going to be virtual ASCO, disappointingly for everyone. But as ever, there will be a lot of very, very important data coming out there. And then the month, shortly after, we have our screening essential update. That was our second highest achieving meeting of last year, extremely popular, and had very good feedback from that. So please do join in there. I'm just wondering whether actually those dates are slightly wrong and it shouldn't be. That is correct. Sorry, Thursday the 10th and Friday 11th of June. So you've got your Thursday and Friday, middle of June, booked out for a perfect midsummer's evening. So without further ado, we will close that session. Thank you very much for joining us. Don't forget to submit your feedback and you can get CPD points in return. Thank you very much.